So in 1965, Dr. Jack Geiger founded one of the two first community health centers in the United States in this desperately poor area in the Mississippi Delta. And so many of his patients came in with malnutrition that he started writing prescriptions for food. And he would prescribe milk and meat, fruits and vegetables, and patients could take their prescriptions to the supermarket, and the supermarket in turn would charge the pharmacy budget of the clinic. So when the Office of Economic Opportunity in Washington, D.C., which was funding Geiger's clinic, found out about this, they were pissed. And they sent a bureaucrat down to the Delta to talk to Dr. Geiger and basically said to him, "You have to understand, our dollars are to be used for medical care." And Dr. Geiger said, in this kind of like famous and profoundly logical moment, "The last time I checked my textbooks, the specific therapy for malnutrition was in fact food." So fast forward, it's 1995, I'm a freshman in college, and I decide that I might want to be a lawyer. And to test this hypothesis, I sign up for an internship in the housing unit at Greater Boston Legal Services. So I show up the first day on the job, totally prepared to make coffee and photocopies, all the things you're qualified to do when you're 17 years old. And instead ended up getting paired with this totally crazy and profoundly inspiring lawyer named Jeff Purcell. And I remember Jeff called me into his office the first day. I had been there literally minutes. And he said, "I want you to call this landlord and tell this landlord to get rid of the cockroaches in this apartment." So I was thinking, this is kind of cool. I'm almost a lawyer. And I think Jeff could tell that I was thinking that. And he looks at me really intensely and says, "Rebecca, the cockroaches are this big." And I was like, "Okay, big cockroaches. Yeah, I'm on it, big cockroaches." And he looks at me again and says, "The cockroaches are this big." And his hands are getting farther and farther apart. So we go through this a few times, and then finally I realized the thing is, Jeff is just so angry. And there's this moment of kind of truth, and I'll never forget, he slides the slip of paper across the table to me with the phone number for the landlord and says, "Go call them." So I got on the phone and I called the landlord and I said, "This is Rebecca Onie, I'm calling from legal services. You have got to get those cockroaches out of the apartment." And I realized I was angry too. And there was this long pause on the other end of the line, and the landlord says, "I'll do it." And I, of course, say, "But do you know how big the cockroaches are?" And it was this powerful moment of both realizing that at 17 I could actually do something important in the world, but also the first of what ended up being 9 months of conversations that I had with landlords, but also with low-income families in Boston who would come in presenting with housing issues because we were a housing unit, but whenever you scratch the surface, there was always an underlying health issue. So, I had a client who came in, he's about to be evicted, he hasn't paid his rent, but he hasn't paid his rent because he's paying for his HIV medication and he can't afford both. I had moms who had come in, her child has asthma and wakes up every morning covered in cockroaches. And over the course of 9 months, I just grew fixated on this connection between health and poverty, and also this sense of we were just intervening so far downstream in the lives of these families. So at the end of my freshman year of college, I read this article in the Boston Globe magazine about the work that Dr. Barry Zuckerman was doing as chair of pediatrics at what was then Boston City Hospital. And Barry had this kind of radical but obvious vision that a pediatrics department should be a place where kids actually get healthy. And he assembled a dream team of lawyers and grief counselors and developmental psychologists to try to really go beyond traditional clinical care. So I called up Barry at the start of my sophomore year, and with his blessing, I embarked on what ended up being about 6 months of kind of wandering around the hospital. And I'll never forget my first day walking into the waiting room of this pediatrics clinic. There was this endless reel of cartoons that was playing, and the sense of just exhaustion and frustration on the part of mothers who had taken 2, 3, and sometimes 4 buses to bring their kids to the doctor was just palpable. And the doctors, it seemed like never really had enough time for their patients. And I would corner them in the hallways while they were wolfing down their lunches. And I would say to them, if you had unlimited resources, what's the one thing you would give your patients? And I heard the same story again and again, one that we've heard hundreds of times since then, where they would say, every day I come into the clinic and the kid has an ear infection and I prescribe antibiotics, but the real issue is there's no food at home. The real issue is the family's living in a car, and I don't even ask about those issues because there's nothing I can do. I had doctors say, if I can, I take $20 out of my wallet and give it to the patient. And they just say, I have 13 minutes with each patient. The patients are piling up in the waiting room. I have no idea where the nearest food pantry is. I wasn't trained to do this, and I have no help. And that was the critical thing. So even today, in that pediatrics department at Boston Medical Center, there are 2 social workers for 24,000 pediatric patients, not even patient visits, and that's frankly better than a lot of the clinics in which we're located. So the question is, 30 years after Dr. Geiger is doing this work in the Mississippi Delta, I have doctors saying to me, on these issues, we practice a don't ask, don't tell policy. And so the question is, why don't we do what we know we need to do in the case of healthcare? And the thing about healthcare is there's so many things that are actually kind of beyond our control. Will we discover the cure for cancer? Or when a patient's coding in the ER, can we save her life? But the truth is, so much of healthcare is just the choices we make. And the truth is that we already have so many of the solutions in hand. So this is one solution right here. This is the HealthLeads prescription pad. And HealthLeads was born of those conversations with those doctors at Boston Medical Center. And the idea is really simple. When low-income patients come into the doctor's office and the physician or nurse or social worker identifies any unmet resource need, food, housing, heating assistance, that will have an impact on the health of the patient, the physician can prescribe those resources the same way she'd prescribe medication, and the patient then takes the prescription to our desk in the clinic waiting room, where we have a core of college volunteers who then on-site and through weekly ongoing follow-up connect that patient out to that set of community resources. And the thing that's so important to understand, all these years later, we now have 1,000 volunteers. We're in 6 cities, 21 clinics, serving 9,300 patients a year. The most important thing to know about HealthLeads is that it's a distinctly non-innovative model. We're doing exactly what Jack Geiger did 30 years ago, now closer to 45 years ago. And I think the thing, though, about HealthLeads is that our aspiration isn't just to connect more patients to the resources they need to be healthy, but to change the way healthcare is delivered so that these resource needs are, in fact, a standard part of patient care, where clinics are routinely screening patients for unmet resource needs, and then when the needs are identified, there's capacity in the clinic to create these resource connections. So BIF, has this great tagline, connect, inspire, transform. And my question is, how? How do we transform a system? And not, I'm not saying how do we transform the whole healthcare system? All I'm saying is when we want to change a very specific piece of a healthcare system where the solution is known and mostly agreed upon, how do we create that change? And you'd think it's a modest request, when the stakes are so high for patients. And the solution is so simple. We should just be able to do this. But of course, as everybody knows, that's not what happens. And part of it is just this dizzying array of factors that have to be lined up, even for the smallest changes. So I will be the first to say I do not know the answer to this question of how we create transformation. But I do know that HealthLeads is very much in the thick of trying to get to the bottom of it. And I thought I could share today just 3 quick lessons we've learned, things we sort of knew or didn't know, but now really, really know. So briefly, number 1, the first lesson is the old Army adage, amateurs talk strategy, professionals talk logistics, or as one of my mentors often says to me, vision does not change the world, execution does. And it's this idea, that so much of systemic change is about this really kind of frankly, sometimes brutal and often tedious work of just getting things done. So why don't clinics screen patients for unmet resource needs if it's what we know we need to do? The question is, who will do it? The doctors are swamped, the nurses are totally overwhelmed, the social worker is in over her head, who will do it? So here in Providence at Hasbro Hospital, as of just a few weeks ago, we have a new system where the medical assistants actually basically do the vital signs with patients and then ask them about their resource needs. But when we tried that at Johns Hopkins, the nurses just wouldn't do it. And so the clinic director had this great insight of stapling the resource screen to the front of the billing sheet, because as he said, that's the one piece of paper this hospital will never, ever lose. And it's, I think, this kind of sort of unglamorous tactics and intensely operational leadership that really kind of is the birthplace, I think, of true systemic change. The second piece, and the next two pieces actually echo the talk before, which I think is kind of cool. The next lesson is really about this dance, the entrepreneur's dance between model and market. How do you use your product to evolve the market, but at the same time ensure that you move your product to meet the market where it is? So to give a really quick example of this, on the x-axis we have patients, right? So we start with frequent flyers, folks that are in using the ER all the time, acute patients, chronic patients, and healthy patients. And on the y-axis, we have the things that we could either do to or with them. So we have clinical care, we have care management, which is providers basically saying, do the meds conflict, for example. We have care coordination, which is somebody calling and saying, do you know when your next doctor's appointment is? Do you know how to get there? And then we have these social resource connections. So the thing is, historically, almost all the time and energy and attention and money was focused on providing basically clinical care to really sick patients. The good news is that, over the past couple of years, the shift has really begun with a focus on patient-centered medical homes and shifting risk from payers to providers, that increasingly folks are beginning to grapple with the needs of chronically ill patients and going beyond just traditional clinical care to include care coordination and care management. But the problem, as you can see from the diagram, is that HealthLead's model is really, in some ways, outside that system. Ours is a truly preventative model. We work to connect mostly healthy patients who are low income, and so they're at risk, but still mostly healthy patients with the resources that they need to both get and, more importantly, stay healthy. And so there's this dilemma for us, of course, to change the system, we have to operate outside of it. But if we're so far outside of it, will we be irrelevant to the conversation that's unfolding? And that raises the question, do we move the model? So for example, HealthLeads has between 4 and 12 contacts with each patient in between their visits because we're calling them every single week to find out if they've gotten their resources, and we have about a 73% success rate in connecting with them. The question is, do we layer in just a little bit of the care coordination work, asking them when their next doctor's appointment is or whether they have transportation to get there, and in doing so, potentially impact patient no-show rates, which have economic implications for these healthcare institutions, and land ourselves back in the conversation. So I think this is the second sort of learning, is how do you negotiate this push and pull between the ambitious vision for a reformed system and the realities of the current one. And then the final, I think, learning, which very much echoes the last conversation, is this kind of belief that we seem to have that systemic change is the result of accumulated successes. And I have to say, so you all have your little brochures about the conference. And when the BIF writer called me to interview me for this little description, we went through the back and forth, and she asked the usual questions. And there's this kind of awkward pause at the end. And she says, can I ask you one more question? So I say, of course. And she says, how do you do this if you just know you're going to fail at it? And which I actually thought was a totally legitimate question. Because the truth is, HealthLeads is trying to change the healthcare system. And that's kind of almost it's just a ridiculous position to be in, right? How is that ever going to happen? And I thought her question was such a good one. And, for me, I think so much of it is this sense that if the failure is almost inevitable, every victory between here and there is just so much more significant. Every single time we connect a patient to a resource, every clinic that begins to screen and refer, every CEO of a hospital who makes this integral to his plan for his institution, those victories just count so much more. And I think on this sort of notion about this, I actually asked my staff about 6 months ago, I asked them to write Health Lead's obituary. And I said, I want you to write it. It's in the Chronicle Philanthropy. The headline is, Health Leads folds its doors. What does the article say? So there was this kind of uncomfortable shifting in seats, and then people started writing ferociously. And they came back and they said 2 things. They said, number one, if Health Leads fails, it will tell us more about the values we have as a country and our aspirations for our healthcare system than it will about what Health Leads did or did not do. And the second thing is people will say, we gave it our all. And I thought, that's pretty good, I'll take that. But I think there's one more point. And when Bill Gates was interviewed about Microsoft, he was asked what was the secret to Microsoft's success, and the only thing he said was, we learned from our mistakes faster than anyone else did. So really quickly, Health Leads, for example, has been working for about 18 months to get clinics to actually implement this resource needs screen as part of their care delivery, and we've been so much more successful than we thought we would be, but the result is this past year we'll now see 35% more clients than we had imagined, and for the first time in the history of the organization, we have a waiting list. And that was just devastating for us. Here we are recreating the bureaucracy of these other organizations that we try to help our clients navigate. And it prompted a lot of soul searching, but most importantly, it prompted us to put in place a rapid triage system for our clients that will actually help us grow so much faster in the future. So I think I have this belief that basketball teaches us pretty much everything we need to know about life. And I wanted to quote the little-known social change / healthcare expert, the great Michael Jordan, who said, I have missed 9,000 shots in my career. I have lost 300 games. 26 times I have been entrusted to take the game-winning shot, and I have missed. I have failed over and over and over again, and that is why I succeed. So if Health Leads success, and I think one of the aspirations of BIF in this gathering is to transform healthcare delivery, the question is, how do we ensure that when the solutions are known and are at our fingertips, when the innovations are there with us, that those innovations, in fact, yield transformation? And that, I think, is our question. Thank you.